With that, I'll turn it over to the renal pathologists.
Great. Thank you, Kate. So the presentations today are actually going to be all courtesy of our colleague from Alaska, Dr. Jeremy Gittimer, who's graciously joining us, even though I believe he's on vacation this week. And so I'll start with the first case here from him, which actually has two biopsies, an initial biopsy and a follow-up biopsy. And then I'll turn it over to Dr. Najafian, who has a couple of more cases from Dr. Gittimer, who always sends us very interesting and challenging cases to interpret. So let's begin on this first case. So Dr. Gittimer, are you on the line here?
Yes, I am.
Perfect. Thank you again for coming over. So we'll start with your first case here. I abstracted the clinical history you sent to me here.
So 47-year-old gentleman was referred from the Veterans Administration in 2018 for CKD stage 3 with a creatinine of 1.5. Seen in the clinic in 2019. He had complaints of polyuria. His urinalysis had no hematuria, no proteinuria on dipstick. Microscopic evaluation in the office was unremarkable. And the nephrologist felt he probably had non-steroidal nephropathy. He had quite a bit of back pain from a back injury in the military many years ago, and was taking 800 of ibuprofen 4 times a day for about 5 years. Felt he had nephrogenic DI. This is not a nephrologist who's with us, so I couldn't ask her what was going on, but prescribed DDAVP, had a 24-hour urine with 227 milligrams of protein. Followed up again, creatinine was now up to 1.6 to 2. DDAVP was stopped, started on hydrochlorothiazide for nephrogenic DI. Then creatinine was up to 2.7 in 2021. Protein creatinine ratio was up. So my nurse practitioner who saw him was pretty astute and said, this is not normal. Basically worked him up again from scratch. Ultrasound was unremarkable of the kidneys. Urinalysis had an increased protein to creatinine ratio compared to his previous. So she ordered a SPEP, and he was found to have an M spike of 0.6 milligrams per deciliter. And his free light chain ratio was at 58.8, which is a little bit high. And he had an IgG kappa monoclonal protein detected, so we did a kidney biopsy and referred him to oncology.
Thank you, Dr. Gittimer. So any other questions for Dr. Gittimer regarding the clinical background? So thoughts or differential diagnosis before we take a look at the biopsy here? What are some of the possibilities that are going through your mind here? I'll pull up the chat to see if you want to put your thoughts there. So Ben suggests MGRS. And so Ben, do you care to specify a particular type of injury that we might detect on the biopsy related to MGRS?
Cas nephropathy.
Cas nephropathy. Okay. All right. So we don't have a lot of proteinuria, but we do have decreased GFR, elevated creatinine. So perhaps a Cas nephropathy. Other thoughts, ideas?
Hi, Jeremy. Thanks for presenting today. A couple of questions for you. Any signs of electrolyte disorders or sort of proximal tubulopathy or any sort of interstitial type clues from the CAM7 or other workup?
We had some mild hypokalemia, potassium in the 3.5 range, no RTA, and he never had hypercalcemia until 2021 when his calcium was 9.8, so not true hypercalcemia, but on the high end of normal, but no other electrolyte abnormalities.
Any Fanconi-like symptoms at all?
No RTA, so bicarb was 24 to 26 on all of his laboratory data.
Very good. Okay, so let's go in here. And so here we'll go straight into the biopsy here. And I will tell you right up front, since we have a couple of biopsies on this, we'll focus on the key pathologies here. The glomeruli were completely normal. The tubular interstitium was actually fairly well preserved. The key findings here rested with the tubules. And so here we're looking at a couple of proximal tubules, and when the fellows and residents rotate with us, we always tell you that they should be full of like pink eosinophilic cytoplasm that should fill pretty much fill the lumen of the tubule. And at first blush, that appears to be the case, but when you look closer, you could see that there's some kind of chunky material in this Jones stain section that is filling the tubule. So again, just to orient everyone, here in the Jones stain, this black material is outlining the basement membrane of the tubular profile. You can see several tubules over here. And again, in some of these tubular epithelial cells, you can see that there's this eosinophilic or pink chunky material that is filling the cytoplasm of some of these cells. Not all of them seem to contain it, but when they do contain it, some of them are very large and prominent. Now we examined these same materials in other stains. So here's a PAS stain of a similar region. And instead of being eosinophilic here, the tubules seem to be stuffed with this very pale staining material. And so rather than having their normal droplets and other structures that you can see within the proximal tubules, they appear very pale because they're stuffed with some material here that corresponds to that eosinophilic material we saw by the Jones stain. Now, perhaps most striking was what we saw by the H&E stain. Again, we're looking at proximal tubules here, and this really highlights the abnormal material that's accumulating within the cytoplasm of the proximal tubular cells. You can see distinct little granules within these proximal tubular epithelial cells. Ben had previously mentioned light chain cast nephropathy. We did not see any atypical casts within the lumen of the proximal tubules. Instead, the abnormal material that seemed to be accumulating was within the cytoplasm of the proximal tubule epithelial cells themselves. We did not see any amyloid. We did not see any other pathology going on overall in the biopsy. And overall chronic injury was very mild at this point. So then we proceeded to immunofluorescence studies. Again, given the concern for circulating paraprotein, knowing that kappa was the clonality of the paraprotein, we investigated this further using immunofluorescence. So our routine immunofluorescence is done on frozen tissue. So this is barely fixed at all and provided to us. And our technicians cut thin sections and we stain for a variety of immunologically relevant molecules, including kappa and lambda light chains. And so here I'm showing you the same field, and you can orient yourself on these casts, which are present at roughly the same location in these two fields. The casts themselves stain fairly equivalently for kappa and lambda light chains. But that material that was within the proximal tubules and stuffing their cytoplasm stained stronger for kappa light chains versus lambda light chains. Now, at first glance, you might say, well, the patient has a circulating paraprotein, has free light chains. Is this just physiologic filtering of the free kappa light chains into the urine with some accumulation in the proximal tubule cytoplasm? So that's definitely a consideration. We definitely see that with patients with circulating paraproteins and filtered free light chains. But we still had to kind of resolve, why did it look so chunky and granular within the cytoplasm of the proximal tubules? So we had, as Dr. Jefferson already hinted at, a heightened concern for a proximal tubulopathy. So in those instances, because the material that's accumulating within the proximal tubules can be very tightly packed and actually somewhat inaccessible to the antibodies that we use in immunofluorescence on frozen tissue, we performed a second set of studies, this time on the formalin-fixed paraffin-embedded tissue. And to do this study, we actually treat this tissue with pronase, which is a very powerful and strong non-specific protease, which is able to chew up the proteins and release more epitopes to allow our antibodies to bind and have access more of the epitopes. So this particular study was even more striking than the study performed on the frozen tissue, where we saw a slight bias towards kappa versus lambda light chains. Now, with more epitope unmasking, there was a very strong bias of kappa light chains, really highlighting the inclusions that were stuffing the proximal tubules everywhere. Here you can see a glomerulus, basically a negative staining profile over here. And again, you can see all these proximal tubules just stuffed with kappa light chain material, and in the similar field, completely negative for lambda light chain. So here at this point, we had evidence that there was paraprotein that was accumulating within the tubules. And it had an atypical appearance by light microscopy. The question now is whether we could actually nail the diagnosis of proximal tubulopathy. And so we progressed to the electron microscopy studies. So this was really remarkable. And so here at low power, we're seeing several tubules. You can see their basal membranes over here outlined by my cursor. You can see the interstitium over here. You can see a couple of peritubular capillaries, these white spaces here with their endothelial cells lining them. And here within the tubules, you can already see that they're filled not with their usual vacuoles and lysosomes and and mitochondria, but instead there are these kind of dark, very angular shaped materials that are accumulating within the cytoplasm. So let's take a closer look at these. So at a higher power or intermediate power, you can see that these are very crystalline appearing materials. They have very geometric kind of shapes. You can see diamond type shapes. They have hard angular surfaces. They're accumulating within the cytoplasm of the proximal tubules, literally stuffing the cytoplasm and kind of pushing out other normal structures out of the way. At higher power, you can see kind of the striped pattern, a periodic type of substructure, which is very characteristic of paracrystalline inclusions. And what I mean by paracrystalline is that they have some order and symmetry, but they're not completely true crystals having symmetry in all three planes. And so again, you can see this kind of striped pattern, which is very characteristic of paracrystalline inclusions related to accumulated paraprotein. So with these findings, we rendered a diagnosis of a kappa light chain proximal tubulopathy. It correlated with the circulating kappa light chain protein. And it definitely had a crystalline substructure. There are some forms of proximal tubulopathy that do not clearly form crystals, but are still appear to be pathogenic to the proximal tubules, and we'll discuss that in at the end of this presentation.
Hey, Ram?
Yes.
So I guess, did I hear correctly though that in the clinical scenario, there wasn't a whole lot of evidence of proximal tubular dysfunction? It like seems pretty extraordinary that the proximal tubules could actually be functioning with all this junk in them.
Yeah, I mean, I think the creatinine was 2.7 at the time of the biopsy, but there wasn't, you know, as Dr. Gitterman mentioned, there wasn't evidence of RTA or other things. So it is quite striking, given how much material was accumulating within the proximal tubules, that there wasn't more evidence of, you know, proximal tubular dysfunction. Okay, so I'll turn it over again to Dr. Gitterman for a follow-up between the two biopsies.
Oncology performed bone marrow biopsy. He was diagnosed with multiple myeloma. He had a IgG kappa spike and was started on Cybor D and then referred to Mayo, where he resided for 3 months for an autologous stem cell transplant. He was seen by Dr. Gorbatkin on video in 2022. Unfortunately, our physician who was following him died unexpectedly, and our follow-up with the patient was lost. And in 2022, he had a still detectable IgG kappa of 0.6 with a creatinine of 2.1, and his proteinuria had increased to 0.41 on a protein creatinine ratio. So it was requested for a second biopsy.
Thank you. So kind of the main questions we were asked to address with the second biopsy was what is the status of this proximal tubulopathy that was quite dramatic, as Dr. Hall pointed to before, and to see if there was any kind of progression of chronic tubulointerstitial injury. So let's take a look at those particular questions in the second biopsy. So the second biopsy, again, like the first, did not have much chronic injury. There was somewhat more pronounced acute tubular injury. And again, here in this Jones stain section, we can see the nice black staining basement membranes. They're fairly back to back, but instead, again, of being tall, columnar proximal tubular epithelial cells, they were fairly attenuated. There are a few nuclei that we're seeing here. There's a lot more white space. And so this is compatible with acute tubular injury. Now, in contrast to the prior biopsy, we were not seeing as many chunky granular inclusions within the cytoplasm of the proximal tubular epithelial cells. So already, even by light microscopy, we were wondering whether there had been some improvement in terms of the accumulation of these inclusions. So let's take a look at this again in those same 3 stains that I showed to you for the first biopsy. And I'll show you again the biopsy from before. So this is the prior biopsy in 2021 at initial presentation to us, where again, you can see these chunky inclusions within the cytoplasm. Now, currently, you can see that while there's some degree of tubular injury, you really have to kind of hunt and look for those granular inclusions. These might represent some of them, but many of the tubular epithelial cells seem to be free of those inclusions as well on this Jones stain section. Again, this is the PAS section from before. You can hardly see any other structures within the cytoplasm of the tubular epithelial cells. It's a little harder to see on this stain in the current biopsy. But again, we are seeing some evidence of tubular injury, but the cells themselves do not appear to be as stuffed as they were compared to the prior biopsy. And finally, again, this is the H&E from the prior biopsy. You can see dramatic inclusion of all of these very large crystalline material here, somewhat less pronounced in the current biopsy. Perhaps here and there were some crystalline inclusions you can see here, but many epithelial cells did not seem to be stuffed with these inclusions. So already by light microscopy, we had the impression that perhaps there was some improvement of the proximal tubulopathy that we had diagnosed before. Now, interestingly, when we did our routine immunofluorescence on the frozen tissue, we did not see any staining bias for kappa or for kappa light chains in the inclusions or droplets within the proximal tubules. So now that was already different from the prior biopsy, where even by immunofluorescence on frozen tissue, we were seeing a kappa light chain staining bias. We repeated the immunofluorescence now with pronase digestion on the FFPE tissue. And again, we were able to see that there was a kappa staining bias in some of the proximal tubular epithelial cells, though not quite as pronounced as we had seen before, where all the proximal tubules were stuffed with these inclusions. Here we were seeing proximal tubular profiles with only scattered kappa positive inclusions or droplets. And again, no staining whatsoever for lambda. So all the evidence we had so far was suggesting that there might be persistent or recurrent or residual proximal tubulopathy, but there might have been some improvement from the prior biopsy. So what does it look by electron microscopy? So here, again, we can see some tubules over here, a profile at the very top. Again, you could see those angular crystalline inclusions related to the proximal tubulopathy. However, there are other tubules where these inclusions were really sparse or barely detectable as well. And so there was definitely some evidence of tubular injury, some loss of brush border over here, but not all the proximal tubular cells contained these inclusions. And so a little higher power again, in comparison to the prior biopsy where the entire cytoplasm was stuffed with these diamond and very geometric shaped inclusions. Here they were present, but much more scattered in their distribution. So the diagnosis we rendered here was similar to the first. It's proximal tubulopathy that's crystalline in appearance, perhaps persistent or recurrent, but reduced compared to the prior biopsy. And we also saw some acute tubular injury. There was a little bit of a mismatch in terms of the degree of global glomerulosclerosis, which might have been a sampling issue, but overall chronic injury still remained very mild and similar to the prior biopsy. So in the last couple of minutes, let me just briefly discuss this entity, light chain proximal tubulopathy. As Ben had mentioned, it's one of the ways that myeloma can injure the kidney parenchyma. I would refer you to the study from a few years ago. Here they looked at over 1,000 biopsies of myeloma-related or dysproteinemia-related diseases in their archive from 2000 to 2014. So by far, amyloidosis is going to be the dominant kidney pathology that we're going to see. So about 40% of the cases had that on the kidney biopsy. Light chain cast nephropathy accounts for another 25%. Immunoglobulin deposition disease, including light chain deposition disease, was another 20%. So already about 85 to 90% of all the dysproteinemia-related pathology in the kidney is going to be counted by amyloidosis, cast nephropathy, and immunoglobulin deposition disease. So light chain proximal tubulopathy here is fairly rare when we think about it. It's only about 5% of the cases of dysproteinemia that's affecting the kidney. And so this is, again, a fairly rare occurrence and quite striking when we detect it on the kidney biopsy. Some of the findings when patients are diagnosed with light chain cast nephropathy, the majority seem to have this crystalline appearance. A non-crystalline form has been also described, which is a little bit more subtle in appearance. In most of the studies that have been reported, there's a very strong likelihood that this is going to be a kappa light chain that is forming these inclusions. And as we saw in this case, detecting these inclusions on frozen section can be challenging. Maybe only 35% of the time do you see the bias. And you really need that pronase digestion to release the epitopes to detect with higher confidence the light chain restriction within these inclusions. Almost all of these patients will present with pretty extensive acute tubular injury pathologically as well. Now, in that study, it's pretty rare to have a repeat biopsy as we had here with Dr. Gittimer. That study did include 2 patients with a repeat biopsy. And so in that, again, it's kind of hard to make sweeping generalizations here. Both of these patients had somewhat increased tubulointerstitial scarring, a new finding of crystal storing histiocytosis. And so a little difficult to make generalizations about that. Many of these patients received a variety of chemotherapeutic agents as well in their treatment. So finally, just in terms of outcomes and follow-up, and these are some quotes from this paper. So these patients, the best outcome was seen and the lowest mortality in the patients that received stem cell transplant. But there's a bit of a confounder because these patients also tended to be much younger in age to be candidates for stem cell transplant, with their median age of being 51 versus 68 for the chemotherapy alone group. Regardless of treatment, the majority of patients had some degree of CKD at follow-up, even though the serum creatinine might have improved to some degree. So this might be related to the high prevalence of acute tubular injury at presentation, but there's always this higher risk of chronic kidney disease, even if you're able to reduce the load of paraprotein. And so I think that's kind of one of the key main takeaways is that even though there might be some improvement and reduction of the light chain, filtered light chain load, their ability to cause crystalline inclusions or cause damage to the proximal tubule may result in some persistent kidney dysfunction and even progression of chronic tubular interstitial injury. So I'll stop there. We may have a minute or two for questions.
So Ram,
Dr.
this is
Gitterman?
Glenda.
Hi, Glenda.
Hi. When you started this discussion, you said that he had a lot of back pain. Does this diagnosis explain his back pain?
A question I would wonder is whether there's any myeloma involvement of the bones and the vertebral column in the back. And maybe that's a question that Dr. Gittermer might have some more information on.
PET scan was negative and all radiographic studies were negative for bone mets. So there was no backbone involvement. And in fact, it was truly an old injury from the military.
Thank you.
Any other questions? Okay, then in that case, I'll turn it over to Dr. Najafian and Gittermer for the next cases.
All right, good morning. So let me share my screen. Okay, can everybody see my screen? Okay, perfect. So good morning, everyone, and thanks for being present for our second biopsy conference of this academic year. And thanks again, Dr. Gittermer, who are joining us this morning for presenting these very interesting cases. So I'm sharing two cases here, both of whom are from Dr. Gittermer. So Dr. Gittermer, if you could start the clinical history of the first one, that would be great.
Sure. There was a young woman who presented to the emergency room, no past medical history, had had facial edema for a week, lower extremity edema for a couple of days. Was seen in the ER. Albumin was 1.1. So the ER doc called me up at about 2 in the morning, classic. And I said, why don't you get a urine? Let's just look. So urinalysis had proteinuria. I went and looked at it myself in the morning, 5 to 10 red blood cells that were very dysmorphic, and quite a bit of Highland cast. She was hypertensive. She had a normal lung exam, normal cardiac exam. They had gotten a CT angiogram because everyone who goes to the emergency room has to have a CT angiogram, I think. And that was normal. She had a normal creatinine of 0.6. So I told the ER doctor to start her on prednisone, and she was like a super normal human being. I told her, why don't we just admit you, biopsy you right away, and then we'll get you an answer. So biopsied her that morning.
Okay. Thank you. So questions for Dr. Gittermer. A patient is presenting with nephrotic syndrome, some hematuria. If you want to look at the clinical history, 5 to 10 RBC dysmorphic and edema. Differentials, questions before we go to the biopsy? Let's see if I can.
Any recent upper respiratory infections or other infectious symptoms?
No infectious symptoms.
Had she had a COVID vaccine recently?
She had not. She was vaccinated a year previously.
Any joint pains?
No joint pain. Kind of vasculitic survey was unremarkable.
Okay,
What's her
differentials.
ethnicity?
There were African American, Eastern European, and Caribbean. Classic Alaskan.
Okay, what are you expecting to see in the biopsy? If you could chat, fill in the chat box, then I can go over those. Okay. Minimal change disease. Okay, minimal change. Sounds good. Anything else? Okay. So we can go over the biopsy and see if that was the case or not. First, let's look at the light microscopy. So very good sample, actually very high glomerular density as well. So probably the patient is lucky as well in that part. So as you can see, the biopsy core is larger cortex, 30 to 44 glomeruli per level section. None of them were globally sclerosed. The patient is young, and we did not see any significant tubular interstitial fibrosis. So, okay, so far it looks good. Now, all right. So here, for comparison, I put a normal glomerulus on the right side, as you can see, and here is a glomerulus, a typical glomerulus, a representative one from this biopsy. What is the lesion that you're seeing here? Please type in the chat box. Or you can say it if you like. So while you're typing, okay, segmental sclerosis, I like that. So basically here, what we're seeing are the capillary lumina or old patent. Both of these, as you recognize, are periodic acid shift PAS stain. Glomeruli makes you see the glomerular basement membranes and tubular basement membranes nicely, as well as other forms of extracellular matrix. So here, all glomerular capillaries, they look fine. Here, this part looks fine. Here, it does not. And as you can see, we have obliteration of the capillary loops with the position of this PAS positive material, probably hyaline. And here we're seeing very nice, basically, infiltration of foam cells into the glomerular capillaries, which is with adhesion to Bowman's capsule, and that's pretty much what defines this lesion as segmental sclerosis or focal segmental glomerulosclerosis, FSGS, as it was brought up. But the other property of this FSGS lesion is its location. So if we want to, based on the basically working classification that was provided by the Columbia Group, how would you classify this FSGS lesion? Where is it located? So we're looking for landmarks. So for example, in this normal glomerulus, we see that this is the vascular pole. Here, you're not seeing the vascular pole, but instead we are seeing the tubular pole, right? So it looks like that the segmental sclerosis is located at the tubular pole, at the glomerulotubular junction. So that would make this a tip variant of focal and segmental glomerulosclerosis. Okay, so indeed, a good number of glomeruli showed this lesion. So as you can see, again, this is another glomerulus, very obvious glomerulotubular junction, obliteration of capillary loops, influx of foam cells, deposition of hyaline, this eosinophilic material. And as I said, that these features were present in a good number, like 3 to 8 glomeruli per level section On each section, when you were looking at basically serial sections, these numbers on one level could be more than this as well. But 8 to 18% of the glomeruli showed FSGS T variant. As you can see here, this is the glomerulotubular junction, and here clearly it is glomerulotubular junction and shows the T variant of FSGS. Another glomerulus, as you can see, and I want to also draw your attention that in this glomerulus with clear glomerulotubular junction here, we see this proliferation or accumulation of these cells also over the sclerotic region. Not an uncommon finding to to observe these type of cells, or let's say that in general epithelial cells populating over the area of segmental sclerosis, but also, I mean, these ones, you know, they kind of have, I want to say, not quite cuboidal, but they look a little bit plump as well. They look different from these flat parietal epithelial cells. They may look a little bit like the cells that are getting closer to the tubular epithelial cells. Will point into this finding after going over this biopsy.
Bazad, on the last glomerulus, is it a little unusual to see the two tip lesions on the same glomerulus?
To see what?
To see sort of two portions of the tuft.
Yes. Yeah. So you mean the both poles? Is that what you're saying?
Well, two sort of sub portions of the glomerular tuft. Like it looks like sort of two tip lesions rather than
two
one
tip
single
lesions.
Tip lesion.
Yes, yeah. Of course, I mean, you have to also, I mean, for the definition of the tip lesion, first of all, I mean, let me say that it's a, so we consider that if we look at the Bowman's capsule and we divide the Bowman's capsule into different sections, the first 20-25% of the Bowman's capsule close to the glomerulotubular junction, if FSGS is located in that region, we call it tip lesion. Now, you're correct. I mean, we see them. It is unusual to see in more than two locations. However, on the other hand, I have to say that you know, on serial sections, it would also be interesting to follow these and see, I mean, if these are connected or not. In any given glomerulus, we can certainly have multiple loci or multiple foci of segmental sclerosis and adhesion to Bowman's capsule that basically may be categorized as different types. So in the same glomerulus, we can have segmental sclerosis, the hilar region as well, or another region. But it's not usual. It's not common. You're correct in that part. Another interesting finding in a number of glomeruli was presence of glomeruli where we could see that the glomerular tuft is indeed prolapsing into the proximal portion of the proximal tubule. As you can see, it's pushing into that region, but with no obvious segmental sclerosis or tip variant of segmental sclerosis. So we had prolapse of the glomerular capillaries into the proximal portion of the proximal tubule. And this one, it's pretty nice because indeed, I mean, this is almost in another level that the glomerulotubular junction is probably in an immediate section below or above this section. And you can see that one of the glomerular capillaries in these completely prolapse into the proximal portion of the proximal tubule. What is the significance of this lesion? This had been shown by Alex Howie that this is the prolapse of the glomerular tuft into the proximal portion of the proximal tubule. Is indeed seems to be the precursor of tip lesion. In some cases, you know, this can be prominently seen and in some of the glomeruli that they have not still established FSGS T variants, such as in this one. In this other case, you can see that we have the prolapse and also we have the characteristic tip lesion, as well as, again, look at the population of these cells over these areas of segmental sclerosis, definitely epithelial cells that they, although in this one, even the Bowman's capsule in these areas shows activated parietal cells, but they do not look quite flat. And in some of the glomeruli, we were not lucky enough to see the glomerular junction clearly at the level that segmental sclerosis was there, but just by observing that the vascular pole is on the opposite side, you could imagine that this got to be close to the tubular pole and perhaps is a TIP variant. And this was quite a common finding, as I mentioned. Tubular interstitium, tubules were back-to-back, no significant tubular interstitial fibrosis, and basically the vessels were okay as well. Now let's look at the electron microscopy. This is a capillary loop, red blood cell. In the outside, we have the podocytes. And as you can see, the podocytes, instead of having the basically nice food processes and slit diaphragms, they are covered by wide areas of effaced food process. So extensive effacement of food processes, and in some locations, we also have microvillus transformation of podocytes that you can see. Again, food process effacement, which is very prominent, and microvillus transformation of podocytes, very common basically features of podocyte injury. Especially when we see extensive effacement of food process, we tend to think that this is likely to be a primary form of podocytopathy, such as minimal change disease or primary FSGS lesion. So again, microvillus transformation, very prominent, and podocyte food process effacement, quite widespread, were present in this case. In some areas, we also had prominent vascularization of the podocyte cytoplasm as a manifestation of injury, and detachment of the podocytes from the glomerular basement membrane. As you can see in this area, there is partial detachment of this podocyte with accumulation of material that may be a mixture of fluid as well as extracellular matrix in this region. This is an electron microscopic picture of a tip lesion. Very nice. We can see effacement of food processes, but also you can see that injured podocytes are detached from this area. And on the other side, where we have these blue arrows, we can see that there is partial detachment, lifting up of the epithelial cells. And then it seems like the fluid maybe is mixed with the extracellular matrix that is basically turning the segmental sclerosis into a solid body. And one can imagine, so this is the glomerular junction that we're observing here, that the parafiltration that occurs in FSGS lesions is actually occurring and moving into towards the glomerular junction. And Bowman's capsule, as has been proposed by William Kritz. This is another picture of a tip lesion again. This is proximal tubule at the glomerular junction. And you can see here, basically the segmental sclerosis, this small portion of that. And just to orient you, I'm zooming in into that region a little bit to make it easier to better orient yourself where we are. So this is the tip lesion again, the segmental sclerotic part. This is the prolapse of the glomerular tuft into the proximal portion of the proximal tubule. The tubules, they in general, they were okay with some features of acute epithelial injuries, such as basically widening or partial simplification of the basolateral enfolding. And I'm not sure if this detachment is indeed artifactual or not. So our final diagnosis was focal and segmental glomerulosclerosis, TIP variant, and common FSGS TIP variant involving 2 to 8 glomerular, about 12% with extensive effacement of food processes. So before hearing about the follow-up of this case from Dr. Gittimer, so TIP variant of FSGS, about 15 to 18% of FSGS cases are TIP variant, and we're talking about FSGS cases that clinically suspect that they are their primary form, and they do better in terms of remission following glucocorticoid treatment, as everybody knows, in complete remission, we can see in different studies a little bit different, maybe about 50-60%, partial remission about 15% has been observed. But in various studies, that may not necessarily translate to a basically a very good outcome as well. As you can see, in this study from Japan that shows the proteinuria remission, it will look at that. TIP lesion, TIP variant did better than other forms of FSGS, but this is for a composite endpoint of 30% decline in EGFR or end-stage kidney disease. And when they looked at it, and you see the dashed green line, that's the TIP variant. And yes, I mean, it looks like it's doing better from, for example, collapsing variant, but indeed the association was not statistically significant. So it is still, I would say that TIP variant of FSGS is likely a spectrum. One spectrum, they behave similar to minimal change disease. Another spectrum, they progress to basically develop a scarring as well. And more recently, there was a paper published about the contribution of different subtypes or subgroups of the parietal epithelial cells that they cover Bowman's capsule, including the flat parietal epithelial cells. The most of the pecs in the human are like these, and these are the tubular epithelial cells. And then we have the cuboidal pecs that are kind of like transitional, more commonly seen in murine models compared to human, and intermediate pecs. I have to say that also, I mean, a little bit older studies, they were suggesting that these intermediate cells are actually more flat. They were called neck cells with some specific staining properties. But nevertheless, this is a commentary written by Vivek Dagadi and Stuart Shankland. On that paper, I use that basically to go over these different subgroups of PEG cells that in the paper that this commentary was written about by Coop et al. They indeed showed that in the murine models of the FSGS, we have proliferation of these intermediate forms, intermediate type of PEGs that they are stand for CD44. And also interestingly, in the human biopsies, basically the TIP variant of FSGS, it showed like that they have proliferation of these intermediate PEGs as well. So this is an interesting finding that deserves more attention and may shed some light into the pathogenesis of TIP variant. I mean, in the past, in general, why that area is basically more prone for this FSGS lesion in like TIP variant. What is happening? The initial proposal was that it's a factor. It's a combination of the shear stress of the flow, which is maximum at the glomerular junction, as well as the proteinuria causing tubular toxicity. But this is certainly providing now more insight into the pathogenesis of FSGS lesion. Okay, Dr. Gitomer, if you would like, please provide us with some follow-up.
Well, this is only about 4 weeks in, so discharged home, seen in follow-up a week later, still with edema, hypertension, now treated with triple therapy, and still with about 10 grams of proteinuria, remaining on prednisone. And then the initial plan was just prednisone 8 weeks, and if she responds, then taper. If not, then probably add tacrolimus or something else.
Thank you. Questions, comments for me or Dr. Gitomer?
Can I ask what you made of all the hyaline that you mentioned earlier? The hyaline casts?
Yeah, I think she was just intravascularly bind depleted. She wasn't feeling good, wasn't drinking as much as she could have. When I'd seen her in the ER, they'd already, of course, given her a liter of saline. So the next urine that I looked at didn't have as many, so I felt it was probably just pre-renal.
Any other questions, comments?
Would it be too early to see improvement within the 2 to 4 weeks? A response to prednisone, I mean.
Oh, I've had one tip lesion that responded in 2 weeks. Generally, I think it's a much longer term.
I think kids with sort of podocytopathies can respond very quickly to steroids, but adults typically take a little bit longer. So
Yeah, being 26,
excited
she
at
was
this
kind of
stage.
in that, when I see teenagers with minimal change in FSGS, they generally don't respond as quickly as when I see, the 3-year-old.
Okay, thank you. So for the sake of time, let's move to the next case. Dr. Gittimer?
It was a busy last call. 79-year-old hypertension, GERD. Didn't have a lot of data, never saw the doctor, basically. Creatinine was 1.2 in 2019, 2 in August of 22. He complained of 2 months of shortness of breath, some left flank discomfort, swelling for a month, and then called 911 because he was short of breath. Brought to an outside hospital where he had a creatinine of 5.7, a BUN of 108, and albumin of 1.7. Hemoglobin 14, platelet of 172. They called us and we said, well, you ought to probably get a kidney biopsy and get a urine. He couldn't lay flat on the table, so they shipped him to us. We saw him. He had urinalysis with red cell counts everywhere, 2 grams of proteinuria on a protein to creatinine ratio, and INR of 1.4 het panel negative. So we ordered labs and started pulsing him with the thought that he probably had renal limited vasculitis ANCA disease, mainly because our bias is we see one a month and we hadn't seen one for a month. So we figured we had another one. And the pathologist will agree we see one a month.
Okay. So the renal biopsy was performed. Questions for Dr. Gittimer. What are your differentials? And I go back here so that you can see the clinicals.
You already alluded to no pulmonary symptoms, I suppose.
Yep, no pulmonary. He had shortness of breath, but actually, when we saw him, his X-ray was negative for any pulmonary edema, and actually nothing remarkable. He'd had a CT scan at the other institution of the chest, abdomen, pelvis, which was also unremarkable. It didn't show anything that made us think about a pulmonary renal syndrome.
Okay, so for the sake of time, I move, but you can also ask other questions, I guess, after I. All right, okay. So this is the biopsy, still not the high magnification, 18 to 21 glomeruli per level section, 5 to 6 glomeruli, 14 to 27% were globally sclerosed, and there was mild tubular interstitial fibrosis. As you can see, there is not much black in this lesion, in this biopsy. Okay, so now you can provide your differentials for the pathologic lesion, make a diagnosis, or ask a question from Dr. Gittimer. This is a normal glomerulus for your comparison, and this is how pretty much every single glomerulus look like on this biopsy. What is your diagnosis? Okay, so let's have a closer look and go over the findings. So basically, I mean, what we're seeing in this glomeruli, in contrast to that normal glomerulus, where the glomerular capillaries, they were patent and were able to see many red blood cells. In this one, as you can see, the glomerular capillaries are filled. They're filled with swollen cells. And also, if you ask me where is mesangium, where is the glomerular capillary, I will have a hard time to exactly show you where these things are. And so there is endothelial swelling, and for the mesangial part, there is mesangiolisis, as I mentioned. And also the red blood cells, you see, oh, there are these little red blood cell fragments and here and there. So with those findings, of course, the differential, or the basically the lesion, the pathologic diagnosis, on top of everything else, is thrombotic microangiopathy, acute thrombotic microangiopathy. And as I said, that this was a pretty uniform finding among the glomeruli. All of them, pretty much, they look the same. This is a mass and trichrome stain that is good for looking at fibrin as well as the red blood cells. We did not see obvious fibrin, but instead, you see that there are areas of mesangiolisis with very nice red blood cell fragments throughout the capillaries. Another glomerulus, mesangiolisis, endothelial swelling, very prominent. Some areas, maybe some GBM duplication, but most of it, it's acute. It's pretty acute. It's still not quite prominent GBM duplication. And we have red blood cell fragments. So acute thrombotic microangiopathy, there was mild tubular interstitial fibrosis with some focal active interstitial inflammation, including lymphocytes and plasma cells, as you can see in this picture. In terms of vessels, we did see some arterial hyalinosis, but no thrombotic microangiopathy, fibrin thrombi, or red blood cell fragments in the arteries or arterioles. And there was concomitant acute tubular injury with vacuolization of the tubular epithelial cells and flattening of tubular epithelial cells and loss of brush borders as well. Electron microscopy faithfully also showed the same things, correlated well, mirrored well with the light microscopy findings. So this is the glomerular basal membrane. We have prominent expansion of lamina rura interna. In the mesangial regions, we have mesangiolisis, loosening of the mesangial matrix, and very prominent expansion of lamina rura interna. This is a closer look at the glomerular capillary beside expansion of lamina rura interna. We see endothelial lining. They're swollen. They're usually very flat, and they have many fenestra. Here we have loss of fenestrations, and we have swelling of these cells. Again, prominent mesangiolisis. You can't find here. It's even difficult to say whether this is mesangium or there used to be endothelial lining. So very prominent mesangiolisis all over the place. And some red blood cells or red blood cell fragments, as we observed in the light microscopy as well. Again, kind of similar to the prior case, but less prominent than that is still some podocyte food processes are preserved. We have significant food process effacement. We have microvillus transformation, but in some areas, as I said, food processes are also preserved. So kind of different from primary podocytopathy case that we presented prior to this. Very prominent mesangiolisis again. And in this area, maybe we see early duplication of the glomerular basal membranes and mesangiolisis and endothelial swelling. So the diagnosis is acute thrombotic microangiopathy, diffusely involving glomeruli, acute tubular injury with some chronic changes. And then basically, we mentioned that there is no obvious involvement of the arteries and arterioles by acute thrombotic microangiopathy. And as we know, the differential diagnosis for TMA is pretty broad. And it includes, but not limited to, viral infections, autoimmune diseases, malignant hypertension, systemic sclerosis, endothelial toxins, TTP, atypical HUS, etc. Okay, so for the follow-up and the additional finding that we figured out after the biopsy, I passed the stage to Dr. Gittimer.
So we actually, after pulsing him for 3 days, starting him on dialysis, he looked like a rose, felt great. So we discharged him for outpatient dialysis, dropped his prednisone to 60, and we're just waiting for the result. The result came back as TMA. We said, huh. So I was seeing him outpatient in our hospital outpatient dialysis unit. So we ordered a TMA panel, Adam TS13, and some atypical HUS gene testing, just because he had no fever, no neurologic symptoms, nothing that I usually think about with TTP. His platelet count was 82 on the day after on the day of discharge, and was 142 when he was admitted. On the day that I saw him after the biopsy, he still had a hemoglobin of 13.4, platelet of 76, and LDH of 206. So being our bias up here, we always think HUS as opposed to TTP. Ordered everything and were surprised when his Adam TS13 came back at 16 with an inhibitor. So we then admitted him. Unfortunately, he had COVID and started him on plasma exchange and steroids again. And then rituximab was given. At the time of discharge, after about 10 days, still dialysis dependent, platelet counts were still in the 70s. Hemoglobin had drifted down, but no hemolysis. I think this was iatrogenic blood loss, and is now following up outpatient.
Okay, so because we actually ran out of time, not that running out of time, if anybody has questions, comments, maybe a couple of questions.
And I might actually, if recognizing the time and needing it to get to another conference, if others are able to stay on for a few minutes, maybe the fellows, and have more of a discussion, feel free. For those who need to go on to the next conference, we will do that as well. But thank you for 3 really excellent cases.
Sure, thank you. So questions, comments from fellows, those who can stay? Okay, so I mean, I have a question I would like to know. So in this particular case, I mean, among the different reasons for thrombotic microangiopathy, and now we see that okay, the Adams 13 was 16 with inhibitor. So I guess that the question is that for the underlying etiology, to nail it down, what would be the next steps that we need to take? From a clinical standpoint of view or diagnostic standpoint of view.
But I guess one question I had is there a monoclonal gammopathy? Is there a underlying pure protein responsible for the atypical HUS?
Yeah. And I don't know if Jeremy, did you check for that?
Yeah, serum protein electrophoresis was unremarkable.
Okay.
Yeah, I don't know why he developed an inhibitor. But
I don't know. I mean, there are some reports that COVID, for example, can be associated with reduced Adams 13 activity. I don't know in this case, you know, the COVID was diagnosed after the biopsy, whether the patient had it, and I don't exactly know what is the natural history, what is the time course that we expect for that, or any other type of infections, or just an autoimmune background.
COVID was 9 days after his first presentation,
Okay.
and he had 2 COVID tests at that time, which were negative when he first presented.
Okay. So likely not. So what is your plan, how you want to follow up this patient?
We stopped plasma exchange because we felt he was reasonably stable, and we've got him on steroids, rituximab, and we're just waiting to see. There's a new treatment for TTP for essentially failures that we were considering, but we wanted to give him a little bit of a chance to respond. He only was discharged 3 days ago, so he's only been on appropriate therapy for less than 2 weeks. So we were sitting on our hands and doing nothing for a couple more days.
Any other questions, comments from anybody? Okay, well, thank you very much, Dr. Gittimer, for joining our conference, and thanks, everyone.
Thank you.
Thank
Thanks. It
you.
was really nice, Bazad and Ram. Beautiful presentations. And thanks, Jeremy.
Yeah, thanks, Jeremy.
Nice seeing you, Charlie. You guys are great. I appreciate everything you
Very
do.
much. Greatly appreciate it.
Thank you. Take care.